Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, shoulder and elbow surgeon at the University of Utah in Salt Lake City. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, or the institutions of any of our guests. Okay, so today I'm at the American Shoulder and Elbow Surgeons annual meeting in Atlanta, and I invited a few speakers to talk on the podcast about the work they presented at the meeting. And for each of these little mini episodes, which we'll make into one big episode, I've been fortunate enough to be joined by a guest co-host. I hope you'll enjoy these, and they'll give you just a taste of all the great work being done by the members that are members of our society that's being presented at our meeting. So I'm sitting here today with Dr. Stephanie Mew of Henry Ford in Detroit, who's going to talk to us about her study, Cemented versus Cementless Reverse Torsional Arthroplasty for Proximal Humeral Fractures in the Elderly, a Multicenter Retrospective Cohort study. Stephanie, welcome to the podcast.
Thank you for having me, Peter.
And joining us today's co-host is Dr. Vani Sabesan at Atlantis Orthopedics in Florida. Vani, welcome to the podcast.
Thank you.
Okay, so let's start at the beginning. Stephanie, can you tell us just kind of a brief summary of your study?
Sure. So what I did is that I reached out to about 7 to 8 different level 1, level 2 trauma centers that take care of proximal humerus fractures. And we retrospectively reviewed from 2012 to 2020 our proximal humerus fractures. Now, these centers treat these proximal humerus fractures for reverse differently. Some do cemented, some do uncemented. So I was curious, because of the trends of reverses going more and more towards cementless, that's pretty much the gold standard now. Can we do that for reverse fractures? There's always a concern about tuberosity healing, metaphyseal bone in these osteoporotic people. So I was curious whether or not cementless fixation in the humerus would be appropriate for these patients. So basically, we reached out to these centers, we collected the data, and we're here to report our outcomes based on the information we gathered. And to our knowledge, it's the largest cohort in terms of reported data.
How many patients did you have?
217.
Wow, so that's a big cohort.
Yes.
And then for those 270, did you exclude certain patients, like with proximal, distal extension or?
So, we really just left it with proximal humerus fractures, 3 to 4 part fractures that required reverse total shoulder, no revisions. So these were not for malunions or non-unions. These were really for more acute fractures. We didn't necessarily exclude distal extensions into the humeral shaft because we felt that still if they're using it for reverse shoulder arthroplasty, if they're going to use it for cemented or cemented, we'd like to know what the outcomes were.
How was your cohort divided?
We basically looked at the cement.
How many people were in the cemented?
So in the cemented, there were 78. In the uncemented, we had 139.
Okay. And when you looked at that, were there characteristics between the patients similar?
Great question. So when we looked at the demographics, there's really no difference in terms of gender, race, BMI, smoking status, which is obviously one of the concerns, and age. So overall, we didn't see much of a difference in the demographics.
And what about surgeon preferences? Were there any particular sort of, if we looked at specific surgeons that always cemented versus other surgeons that didn't?
So you mean in terms of demographics or
just in terms of the patient treatment algorithm? Yeah,
certainly. Each of these sites each of them were predominant one style, So there's about 3 or 4 centers that treat all their fractures at this point, majority of them uncemented, and then there's other sites, mine being one of them, we treat them cemented. So it's definitely surgeon preference in terms of the fixation.
Now, before we get to the results, let's just hear. So, Vani, for your current reverse for fracture, what's your protocol, cemented or cementless?
I do cementless.
What kind of stem do you use?
So I try to find a metaphyseal fit stem. So I have changed my characteristics so for a primary reverse, I do a short stem, uncemented with proximal fit. And then for a fracture for reverse, which I tend to do a lot of in Florida, I've gone to more longer metaphyseal fit. Some of them that are separate and not an en-bloc stem. So they're modular in components. And I found that also seems to improve my fixation.
This is perfect because I've been cementing them. So now we have one person on each side. I wish I could say I coordinated that, but it just happened. So tell us now, what's the results? Who does better?
So in terms of surgical time, as you can imagine, OR time's more for cemented, just for the cementing and securing. But in terms of intraoperative complications, we didn't see a difference. Overall complications, while there were more in the uncemented group postoperatively, did not reach significance. Function was similar. But in terms of objective failure, in terms of revision rates, there was more in the cemented group, and that reached significance compared to the uncemented group, actually.
So can you tell us a little bit about those results? So when were we looking at? What's the timeline? How far out?
So that's
did you
great.
follow people?
That's a good question. It's really short-term results, just because a lot of these fractures were lost to follow-up, just the nature of trauma. So in the cemented group, the follow-up is about 10 months, and in the cementless group, it's about it's about twice of that, so 16 months.
Okay. And then when you looked at that, like in terms of our short-term results, were you able, like, did you look at radiographic results too?
Yeah, so we attempted to, obviously, looking at this, and we found a higher radiolucency around the cemented group.
Okay.
Now tell us about tuberosity healing. I've been sometimes concerned that like cement gets in the interface between my stem and my tuberosity, or between the shaft of the tuberosity, and prevents it from healing. Did you see any differences there?
So that's a great question. Unfortunately, that's something we didn't look at, but we are in the process of going back and thinking about going back to see if we can gather that data, because that's the more and more I'm looking at it, I think that's an important aspect of whether or not the cement, can play a role, whether or not the tuberosity heals.
What do you think is driving your results? Like, what do you think causes the
Yeah,
potential
why am I
functional
better?
differences?
I didn't say
Oh my
better,
God.
so we didn't
Don't
say
make
better.
me regret this. Yeah.
It's a hard question. It could be cement technique. I think that could be a big one. It could also be in terms of, this is short-term follow-up, so we don't know how the ingrowth or on-growth, depending on the stem that is used fixation-wise. We just may not have seen the failures or loosening in that terms. But when I do a cemented stem, I tend to let them go faster. So maybe I shouldn't be doing that in these osteoporotic patients. But beyond that, I don't. To be honest with you, I don't know why. I was a little surprised, to be honest with you.
Can we ask a little more, like exploring that? What were the complications when you talk about that? Because they said they were higher, but
Right.
maybe it's, what were the types?
So in the overall, there were like 18 different complications, but the most common were periprosthetic fracture, a acromial fracture, this, like I said, the stem loosening, and then we had actually 2 infections in the cemented group. All the other ones were a bit smaller in terms of neuropraxia. I think there was like 1 superficial. There's a lot of ones, in terms of complications.
Now, obviously, this is always hard in a retrospective comparative study,
Yes.
Because do you think there could be some selection bias where patients with worse bone intraoperatively, the surgeon said, well, we should cement this one, the bone's not so good.
So,
Are we selecting out for the patients with osteoporosis by the study design?
Yeah, so that's a great point. Certainly we could, but when we looked at the centers, they tended to.
They stayed, so by the
Yeah, they
surgeon
tend-
centers,
right.
they stayed
They
consistent.
stayed consistent. There were a few times where you would see some centers maybe fluctuate a little bit, but overall they tended to stay consistent with how their fixation technique was.
One thing that I've seen since I kind of moved from a cemented to cementless sort of technique is, you really worry about the type of implants you use and the sizing. And some of the options in some of the companies have not been as, in terms of implant sizing, have not been as vast. And so the solution is you just cement a smaller component in. Whereas when you have to get a metaphyseal fit or consider uncemented, you really have to have a good fit, right? And so it forces you maybe to try to push that sizing, get the right fit. And I have changed my implant selection based on that. And that has been a big thing. And then the second thing I noticed too is a lot of the cemented stems have a much larger proximal body than uncemented ones, if you look. And so, it's just a thought.
Yeah, that's a great point. I know there's a couple companies out there that purposefully had smaller bodies to allow for, fins to
Yes.
allow for tuberosity fixation. So that's one of the things we, obviously we're not able to control for. We know that there are some surgeons that just used a primary stem and then they just used it cementless, and they just felt that, with cerclage technique, they were able to get a good tuberosity fixation. That's a great, point, but as you're aware, it's very hard to to look at retrospectively.
So now tell us, Stephanie, before you did this study, were you cementing or cementless?
Cementing.
Cementing. And what are you doing now?
Still cementing.
Okay. So
But
the study didn't change your practice.
Well, I have to admit, I mean, looking at this, and I'm tempted to do cementless, but my problem is that these are very osteoporotic, often osteoporotic bones. So my concern is putting these huge stems into very, very thin bone, and and whether or not how well they'll do from these, or if I'm going to create more problems by putting these fit and fill stems. I probably have to look more into these maybe more modular type of systems. But that's probably one of my big concerns still in terms of going uncemented in these osteoporotic patients.
And I mean, at least the one thing it seems like is technically they're both difficult, and it sounds like people sort of have their preferences and seem to hold on to them, right? So, as we continue to teach and train younger people, maybe sort of making sure that they're technically gifted in both types of fixation. Absolutely. And understanding that's probably going to be important to prevent complications.
Maybe you could provide us, Vani. I mean, you're using a cementless technique. It sounds like there's some advantages to it. Maybe the data suggests there is a slight advantage in terms of complication rate. What are some technical approaches to getting that done?
Well, I think that understanding your system is important. I think, the preparation, as Stephanie puts on, I mean, intraoperatively, these are bad bone patients, right? So just being a little bit more cognizant of your preparation and how you do it. And then I think the modularity helps. I think not over-lateralizing has been another thing that I've really changed in my practice. That putting a lot of tension on the cuff and tuberosities can cause a lot of failures. And I've kind of swung back the other way with fractures for reverses. And then I think, one thing that Stephanie points out that we really always talk about is like postoperative rehab and recovery and the importance of that. And so I've slowed them down a bit more postoperatively, not necessarily in terms of their moving, but in terms of strengthening and sort of pushing the envelope on that. So I've kind of modified my activities a little.
So slowed them down. How long are you putting them in sling for?
So I let them start moving. I do active assist range of motion, but I limit their external rotation and abduction. So I kind of let them do in a forward plane, some active assist, and then I don't start strengthening for 6 weeks. I'm probably more aggressive than most people on rehab. And thus far, I have been following, and I have a small cohort of fracture for reverses, and I have not seen any increased failures on the tuberosity side with some active assist range of motion.
How about you? So reverse for fracture, how long for sling, how long for motion, how long for strengthening?
So I typically just let them be in a sling for about a week for comfort after the surgery, and then I get them into basically my standard rehab protocol for reverses, which is, passive active assisted motion. They're out of the sling after a week. And then they can start strengthening as soon as they have gained their full sort of active assisted motion and therapy. Because my belief is sort of I tell them they can be very strong, but it doesn't do them any good. They don't have the motion to be able to get to the the range that they want. So they can do isometrics, but true sort of active strengthening, I guess, would probably be around 6-8 weeks.
Any other final thoughts on this paper? This is a great study. Thank you for sharing this with us.
No, I think you guys have brought up some great points. Some of these things I am looking at to, further look. And I think the most important things, right now the literature is quite sparse on looking at cemented and uncemented. I think with this cohort that we have, really the power of this will be to look at it long term, more of that 5-year data, see what we're getting in terms of the results on that.
Also, maybe, future studies, what should we be looking at? What do you guys think in terms of this? Because to me, it's a practice shift, right? A paradigm shift that we could make. What should we be looking at? Should we be doing registries, larger cohorts?
Yeah, I definitely think registries are important. The ASES has a registry. We could get everyone to, follow that data. I think also, in terms of we may have to be more aggressive in treating the osteoporosis. So, recently I was in Asia for the traveling fellowship, and they're quite aggressive in treating osteoporosis. They treat their patients, even for routine reverses, with parathyroid hormone a lot of times. So that is something.
Well, it's interesting you say that, because I think Gulata is doing a study that looks at nasal calcitonin to try to improve things, and perhaps we should be thinking a little beyond the outside the box of metal.
Right.
I
Because,
do think it's really critical for these patients that you have a colleague you work with who treats metabolic bone disease. I refer every single proximal humerus fracture I refer to a colleague I have who evaluates them and then determines
Absolutely.
whether it's calcitonin
Right.
or parathyroid or bisphosphonates or whatever it is.
Right.
But if not necessarily for this fracture, but so that the next time they fall down, they don't break their hip.
sure. No, and I agree that we do the same at our institution. We send them all to a bone health clinic.
Really critical if we do that.
And I wonder, as surgeons, should we be more aggressive in trying to also just treat the current fracture on our own? Because a lot of these times we send these people to endocrinologists, right? And they're thinking along the endocrine line, or more of like, what's a BMD? Well, how do you treat that? But in terms of bone healing, maybe we can take a different approach and be more aggressive in trying to treat they probably have some form of osteoporosis, whether or not they hit the critical numbers on their bone density.
No, and you're very right, because in Europe there was a study done on hip fractures in the similar sort of fashion, and looking at augmentation with PTH analogs, and maybe a short course of that could enhance healing. And so maybe we need to be more of an active participant, because when you send them to these bone clinics, the tendency is to wait till the fracture's healed to do any treatments. And so perhaps that's the most critical time period, is while they're healing. And maybe we as a community need to take the wheel on that.
I agree.
Well, thank you both for coming on and talking about this. This is a great study again. Congratulations, and we'll look forward to the next steps. Okay, so I'm here with Dr. Albert Lin of Pittsburgh, Pennsylvania, and Albert Lin is going to talk to us about his podium for tomorrow. Increased lateral humeral offset beyond anatomic is associated with diminished strength and range of motion following reverse torsional arthroplasty. Welcome to the podcast, Albert.
Thanks so much for having me.
And then as a guest host, we have Dr. Hatzidakis of Denver, Colorado, who's going to give us his insight into this. So welcome to the podcast, Armand.
Thank you, Peter.
So Albert, tell us, what is this study? What did you do? What did you find? Why did you do this?
Yeah, so I think the trend right now is towards lateralization of reverses, right? And there's some studies demonstrating better range of motion, decreased scapular notching, maybe lower complication rates. And the question everyone has is, what is the optimal lateralization, right? And I don't think anyone really truly understands that. It's based on a lot of clinical studies, cadaveric studies. And so we, over the last year, have been doing an RO3 study with in vivo kinematics, actually looking at patients moving with their reverse implants and looking at surgical characteristics. And this is sort of an offshoot of that study. And so what we're able to do with this study is to be really, really detailed in sort of how we measure strength, how we measure humeral retroversion, and how we measure certain parameters that I don't think really quite understand. And so that's sort of the premise of the study. The Freddie Fu thought was always, anatomic, or going towards anatomic was always better. And I think there's this idea, even though reverse replacement isn't an anatomic replacement, there's this thought that maybe going towards anatomic is a good thing rather than a bad thing. So that's the premise of it.
Okay, so the idea here is lateral humeral offset retroversion. It sounds like you have a lot of data, and this is kind of a peek into just strength, range of motion. Tell us what you found.
Well, and so what we found is when we looked at, so we measured strength using biodex. So in a couple of planes of motion, we actually measured retroversion using 3D models. And so this is very accurate ways of measuring retroversion. I think that's one of the limitations you have in the current studies, where you do the retroversion bar at the time of surgery and you just assume that it's 20 degrees retroverted or 4 degrees, but you may not actually know. And so what we found is the more you deviate actually from what your native offset is and what your native versions are, that actually the diminished strength and range of motion that you get. And it's actually a little bit counterintuitive. Our hypothesis actually going in was that we thought, hey, the more offset you're going to have, the better strength, the better range of motion, the more retroversion, maybe the better external rotation. But actually, conversely, what we found was it's not really the absolute value that matters. It's maybe sort of the change from your native to to what your implant gives you. And so if you go way beyond lateralizing what your native is, we actually saw that it actually diminished your strength pretty significantly. And in addition, there's a sweet spot where your humeral retroversion and lateral offset go towards native that actually improves your range of motion, which includes actually external rotation.
Now, when you say native, you're saying premorbid anatomy, or are you saying preoperative anatomy?
Preoperative anatomy, and so that's a great distinction. I think premorbid anatomy is a little bit hard to know sometimes, right? And so what we can say is this is the the difference between what their preoperative imaging was compared to their postoperative imaging. And so, a lot of times when you say, okay, we did 5 millimeters of lateralization, what exactly does that mean? It doesn't necessarily mean you did 5 millimeters of lateralization beyond what their native is. We actually don't know what that reference point is. And so here we're trying to give a reference point to sort of how much global lateralization or how much change in lateralization and humeral offset, humeral retroversion that you're giving this patient.
So tell us, what based on this, your recommendation is you try and put the humerus at the same medial lateral position after the surgery as where you started before the surgery, you think?
Yeah, I think this is on 30 patients because of sort of this, as part of a bigger study. So I think we probably need a little bit more data. But I think intuitively, I think what I am kind of theorizing or hypothesizing is that we should try to find some way that we can match what their native anatomy was before surgery.
What are your thoughts, Armand? How much lateralization do we need? How does this alter your thinking?
Well, Peter, I think it's a very fascinating topic because we do tend to talk about these things in isolation. And as we know, there are multiple variables involved. There's glenoid offset, there's humeral offset, there's size of the glenosphere, there is the distalization that occurs. And so when I initially started doing research on this with Pascal Boileau about 20 years ago, we looked at where is the center of the glenoid rotation. Does that matter? Does a medialized center of rotation of the glenoid, the glenosphere, actually help your external rotation because it's medial to more deltoid fibers? So I was curious, Albert, when you looked at this, how did you, because the paper hasn't been presented yet, how did you look at lateralization? Did you just look at the lateral cortex of the humerus? Did you look at the greater tuberosity? Did you look at the deltoid insertion? Maybe talk a little more detail on that.
Yeah, it's a great question because there's a lot of ways to measure global lateralization, like you talked about. You could look at center of rotation. So how we measured it was we took the CT scan preoperatively, and then we found the medial border of the coracoid and just took the most lateral aspect of the humerus. Okay. And that was a reproducible measurement. And this has been prior described. And so we just use a very reproducible measurement for those 30 patients that were involved in our study.
Could you then correlate fatty infiltration of the teres minor, infraspinatus? Could you look at that as a way to look at external rotation as well?
Yeah, absolutely. I believe I'd have to look at our study in a little bit more detail, but I don't believe that there was a tremendous skew towards these patients having increased fat infiltration in their external rotators. But that's, I think, a great point in terms of strength and power.
Were there different implants used?
2 different implants. So one implant was a 135, I would say, inlay-ish type implant, not completely inlay, with flesh lay, I guess I would say.
Or mini onlay?
Yeah, exactly. Mini onlay.
Yeah.
And the other one was a 145 complete onlay implant. Yep.
Now tell us, how does this, you've talked a lot about humeral offset on the medial lateral plane. How does this affect distalization? I mean, certainly I think those things are interlinked.
Yeah.
Did you look at that as well in your study, or is that coming in the future?
I think that's another parameter we're trying to look at. I think the difficult thing with doing these type of studies on reverses is that there's so many parameters, and we try to be as isolate them as much as possible to get clean data. But I think distalization is something we're looking at, like eccentricity as well, and other parameters, tilt, glenosphere size, so on and so forth.
Albert, I just have to comment on the retroversion question. I think it's a great avenue of research you perform because it's a very difficult thing to evaluate, as you've noted. And I remember when the reverse was first coming to the United States, guys like Anders Eklund, our experts from Sweden, came in and said, listen, if you want more internal rotation, you should neutralize the version of your component. Yeah. Et cetera, et cetera. But what I've noticed in my practice over time, and I'd love to hear you both of your comments, is that if you change the retroversion too much from anatomic, it changes the stability profile, changes the ability to reduce the implant. And the other thing I've noticed in my own practice, because I believe in the anatomic version, which you were asked about earlier, is that it seems like for my cases, the retroversion may be 45 degrees in some cases, or 50 even, because as we know, there's a large physiologic difference in different patients. And what I found, at least in my personal experience, is that if we have a little bit larger glenosphere, not too lateralized, and respect the native version, not only is the external rotation better, at the end of the procedure, the external rotation is good, the subscapularis can be repaired, but functionally they regain their internal rotation as well.
Yeah.
So I don't know if you have any comments from your study. I know that's not the focus of it, but do you have any additional investigations that are looking at internal rotation?
I mean, I think that comment is actually dead on. I think it always, when I trained, and I'm not sure with you, Peter, when I trained, we were taught to put the retroversion in around neutral and 10 degrees, and it always looks so far off from the anatomy. And it was always a very strange cut, and you do this cut, and I completely agree. I think it changes the stability profile. I think it changes the range of motion profile. And I think what's interesting is that we base our retroversion on these bars. We literally just line it up to the forearm, but it may actually have no... that forearm bar actually may have no real bearing as to real epicondylar access, and in fact it most likely doesn't. And so we're judging these retroversions based on and we're so specific with everything else. Our pre-op plans on a glenoid, completely very specific 3D planning, etc. And then yet we go to put our humeral implant in, and we use a forearm bar to match it parallel. And who knows what version you're actually really putting it in. But my personal feeling, I completely agree with you. I think if you put it a little bit closer to the normal version, I think you get both internal and external rotation benefits.
It's super interesting. I mean, I think it's a great study. We've tried to do some of this similar work at Utah. It's hugely challenging work to do this kind of 3D analysis, but it's so beneficial. So congratulations to you for all this work. What are the next steps? So where are you going to take your study findings from here?
Yeah, I mean, I think the next step really, I mean, when we started this R03 grant, it was a small study just to look at patients who actually had the implants in already. So they were patients who had had implants in for a number of years. And we tried to get a wide distribution of variables just to see, hey, what are we going to find when you look at it in vivo analysis? I think the next step here is then to take this data, and if we really strongly believe in this, okay, maybe we want to reproduce lateralization to be closer to anatomics, or retroversion closer to anatomic. Really the next step would be to use that intervention, I think, and then to really follow that in a prospective way. I think that's sort of what our goal would be, with more number of patients using the data and affecting our surgical techniques.
Well, I think this is great work. Certainly, for me, this is another brick in the wall being built, that supports the anatomic reverse torsional arthroplasty. And then I think we're getting away from maybe reverse anatomy being the right answer to innate anatomy being the right answer. What are your thoughts, Armand? So how does this affect your thoughts? Is this what you were already doing? Did you already know this?
I wouldn't say I already knew it, Peter, but it makes a lot of sense to me, and it seems to be in my clinical practice something that I've gravitated towards is more the anatomic positioning. The one thing I think would be very interesting is that we have two distinct populations of reverses that we have at this point. Mm-hmm. We have people who are traditional rotator cuff arthropathy. They may have no subscap, supra, infra. They have little teres attached. Yeah. And then we have the population of people who have a pretty good rotator cuff, but their glenoid's not sufficient to support anatomic prosthesis. So I think it would be fascinating to look at those two different populations, because I suspect we will have to do slightly different positioning, maybe a little more lateralization in the deficient patients.
Right.
But whereas in an anatomic patient, respect the anatomy, get a little bit of lateralization, make sure the glenosphere is big enough to get an arc of rotation. Yeah. Probably good enough in a truly anatomic shoulder, but with a severe B2 or B3 glenoid. In our rotator cuff deficient shoulders, I think that's going to be very fascinating, your work, because that to me seems to be the big trade-off patient. Okay, are you shooting for elevation? Yeah. If you have elevation in the absence of functional external rotation, and you're relying on the teres minor, which is there, right, but then you change the mechanics such that they lose external rotation, which did happen in the early days of reverses. Right. The patients would say, I could eat before surgery, and now I can't because of the changes in mechanics. So to me, Peter, that's where it will be really fascinating to see the two populations and see what recommendations how the recommendations will be different, Albert, from your future studies.
Very great point.
And yours, Peters.
Yeah, no, I think it's a great point that we need to specifically understand the role of the infra in the reverse.
Mm-hmm. Absolutely.
And how does it, if it's absent, how does that change the way that we do the surgery? And that's not about the bone.
Mm-hmm. Right. You're absolutely right. Yeah, the soft tissue tensioning. Right. I wanted to ask you guys a quick question too. So, how do you think this might play a role in sort of our pre-op planning, right? So we have a lot of good glenoid planning. We have a lot of good, we're starting to develop some, center of rotation type planning, on our softwares that I think most of us use. Why do you think that there's no humeral planning? And because I think that probably is an important thing.
I totally agree with you. And I think even beyond that, though, you can make a plan, but then how accurately are you executing it?
Yeah,
That's my issue
And
with it.
we have that on the glenoid now, and we have a lot on the glenoid. People make guides.
Yeah.
There are systems for navigation. There are no current humeral navigation systems. So is that coming in the future? Will that affect our outcomes? Do we need to do that? I don't know.
Yeah.
But I do think we're going to see that. And I think we may see that makes a difference. We'll see. What do you think?
Yeah, I agree totally, Peter. I think it's a great question, Albert, and I do think that that's possibly where robotics will enter our conversation, because intraoperative evaluation of the bone via complex computer software, comparing X-rays, CT, the intraoperative markings on the humerus, and then being able to execute that via robot, and then being able to actually have something beyond ourselves evaluate the bone. Because I think as far as evaluation goes, the human of way to evaluate a humerus and how well we cut it and how much we cut, that I think that may be flawed enough that we need a little help from our.
Well, if I'm you,
More
I don't think I
digitized.
need that, but I'm me, so I think I need the.
I think
need
the same thing.
guidance,
Exactly. I need the guide.
Yeah,
I need the guide. Yeah.
exactly.
Well, thank you both for coming on. This is great work that you're doing, and congratulations on it. Thank you again for your time, Armand, and
you,
we'll look
Peter.
forward to seeing what you accomplish in the future here.
Thanks so much, Peter.
Great work, Albert.
Thanks very much.
So I'm here with Dr. Phillippe Collin of France, who's the current CESIC president, who's going to talk to us about his study, Relationship Between Speed of Recovery of Range of Motion and Rotator Cuff Healing, a study of 1,154 consecutive arthroscopic Supraspinatus repairs. Dr. Collin, welcome to the podcast.
Thank you. Thank you for the invitation.
Oh, thank you so much. And we have two guest hosts joining us, staying over from our last podcast. We have Dr. Albert Lin, as well as Dr. Armand Hatzidakis. So we have plenty of discussants here. So let's start. Dr. Collin, tell us just a brief summary of what you found. What did you do this study for? What did you find?
So I have a huge database. I have the opportunity, and I'm lucky for that, to have the possibility to follow up all my patients at 6 weeks, 3 months, 6 months, 1 year, 2 years, 5 years, and 10 years. Everything is organized like that in my institution, and we can make an ultrasound examination at 6 months for everybody. So that's why I have this database. And I thought in the past, and I wanted, in fact, to have speed recovery. Because when you teach physios and everything, we move from something was very, very difficult for the patient with a huge brace and something like that to almost nothing. And everybody went in this way. So I just wanted to check if it was okay or not. So regarding what I said previously, I have a huge database. So I wanted to have at least 1,000 cases to know if it was good or not. And I definitely thought that it was a good way to go. I thought that it was a belief. Mm-hmm. And then because I've read from the literature that it's good to move as quick as possible in order to improve the quality of the tendon. And unfortunately, I was totally wrong.
So you had thought that this accelerated recovery was going to be to the benefit of the patient, and then what did you actually find?
I found that so previously, it is very, very important for me to clarify this. A correlation is not a cause. Mm-hmm. Definitely not. Mm-hmm. We often make this mistake. So what I can share with you, with all my colleagues, is the fact that I observed something which is not going in the way of the best healing if you move very quickly. But is it really correlated? Is it really the cause? I just don't know. Is it clear?
Absolutely. So you found it's unclear if the speed of recovery is the cause of the failure in healing, but what you found, it sounds like, is that the patients who had a quicker return of their range of motion had a lower healing rate.
Exact. If it was absolutely clear with all the statistics, even the multivariate analysis, the fact that the recovery of forward flexion and external rotation at 6 weeks was highly better in a non-healed group compared to the healed group.
Now tell us, this may be hard, but do you think that's the patient moving more quickly? Did you change your protocol during this time period? Do you think that's a scar tissue formation biologic phenomenon? Where does that come from?
So what I can say, I changed nothing.
Okay.
It was same patient, no fatty infiltration, PAT 1, no retraction. So in other words, easy isolated supraspinatus tear.
Right.
The 20 or 30 minutes one that you have in your OR and you don't really think about it.
Right.
Okay. So it was exactly the same patient, same surgeon, double row, and exactly the same protocol, post-op protocol, because I have the chance to work, not now, because now I work in Paris, but in the past I used to work in the small city, and all the rehabilitation was done around close to me. So it was the same physio, everything was the same.
Phillippe, tell us about that physio. What is your usual protocol in rehabbing arthroscopic repair of a very fixable, smaller tear as you described? What can you go through the first week, the first 3 weeks, 6 weeks?
Sure.
Please tell us the protocol.
So it's always the same. So we have a sling, abduction sling for 4 weeks.
How many degrees of abduction?
20.
Okay.
20 degrees abduction sling, 4 weeks. We start rehabilitation immediately with what we call self-rehabilitation. They move by themselves, like that.
So active assistive, basically what Phillippe is showing for those listening on the podcast, grabbing your own hand and lifting it forward, kind of an active assistive type of exercise, as we would call most likely, right, guys?
Yes.
Active
So
assistive.
they do that 3 times a day, and then they have only 3 appointments with the physio every week. So the physio just check if everything is okay. Normally, the goal is to recover all active assisted range of motion at 3 months. When we have this, we start to reinforce the tendon and everything until up to 6 months. So it's very simple protocol, in fact.
So I'm sorry, just so I understand, we understand this. So at 3 months, Phillippe, do they do active motion at 3 months?
Yes.
No earlier than 3 months.
No
It's
earlier.
active assistive until 3 months.
Yes.
And then when do they start resistive work? Strengthening via bands, isometrics, or weights?
Nothing before 3 months.
But they can start all those things at 3 months if they have full motion.
Exact.
Okay.
So the key point for me is all passive range of motion. Because most of the time it's the most important mistake which is done by the physio. They want to do something.
Yes.
They want to do something, especially with the patient who are not doing well.
Yeah.
And then they start to reinforce the tendon, to reinforce the muscle and everything at 3 months, even if they don't have full passive range of motion. And it's a big mistake.
Yeah.
Do you think, this is a pretty, everyone's protocols are varied, right? And this is a pretty quick protocol, I think, to get things moving. Do you think there's any harm in not moving a patient for 4 weeks in the sling?
Probably. I shouldn't. Regarding my results, I agree that I should probably go in this way. But I don't know.
Mm-hmm.
Perhaps they are going to be very stiff, or I don't know. But probably we. I think it would probably be too quick, perhaps. Mm-hmm.
Just to clarify, when you did the ultrasounds, all at 6 months?
6 months.
I thought Ionati's work was very interesting, and that basically the way I summarize this for patients is I tell them, listen, be careful with your repair for the first 6 months, because half the people who re-tear their cuffs tear it between months 0 and 3, which is the time which makes some sense. But it also makes sense that people would protect at that time. People use their common sense. They say, I just had surgery, I'm going to be careful. The real interesting thing to me about his work is between months 3 and 6 is where the other half of the ruptures occurred. So that's what I warn people about, because if you look at some of Gerber's work, Alberto Schneeberger, Christian Gerber's work 20 years ago, when they looked at sheep, first of all, none of these sheep's rotator cuff wanted to heal if you just let a sheep live their life. You had to cement a ball to their hoof to get any of their cuffs to heal. But secondly, it was interesting that the repair of the strength was only 50% tensile strength, even at 3 months. So I tell patients that between months 3 and 6. So do you think maybe, Phillippe, with all of our protocols, we're battling nature to some extent? That we are not respecting nature's speed of healing with trying to be too fast?
I don't know if sheep it's comparable to
Not
human.
right. We haven't done those studies in humans.
Exact. They are strange animals.
Yeah, that is true.
Even if you do nothing, sometimes they heal.
Right.
That's strange. So perhaps we want to compare something which is not comparable.
That's a good point. Well, what do you think? How long does it take a human tendon? If you had to guess, when is a human tendon at 80% tensile strength after rotator cuff repair? What would you guess?
What I would guess?
80% tensile strength, just how much it will hold. It holds 80% of a normal tendon.
I don't know.
That's the question, isn't it? What do you think, Peter?
And I agree that it's really hard to know how comparable sheep data is to human data, but I think the closest you can get is the would be to use an ape, to use a monkey. There's only, as far as I know, a single chimpanzee study that looked at histology, and it suggests that at 3 months it's not healed. The tendon is just laying on top of the bone. And that you need to wait until 4.5 to 6 months to really see restoration of the enthesis, restoration of that nice transition from bone to calcified cartilage and what I think is so interesting about this data is that you were the same surgeon, the same physios, the same protocol.
Exact.
And we have some patients that heal and some patients that don't, and that there's this clean correlation between the patients who have more range of motion early on. So I wonder, are there certain patients that have a more robust scar tissue response? Those patients also get stiffer. Is that an inflammatory thing? Do we need to worry about giving some? Is there some way we could activate that biology, or is there some way we could capture that to better understand it? So what are the next steps? What do we do? What do you do from here?
So in this study, we showed as well that two other interesting things. So the second one is the fact that patients with pain during the day healed better than the others. In other words, if you are a bit painful during the first 6 months, it's probably good. Which is very interesting for us, because you can say that to your patient. You're painful, good news.
Right?
Which is good. Second things, which was very interesting for me, it's the fact that I can understand more now. Sometimes the patients are doing very well at 6 months, but they complain a bit about internal rotation. You've seen that?
Sure.
I've seen that.
Yeah.
And then it was really correlated with healing. If you have a healed tendon, you have less internal rotation at 6 months. I was very happy to check that. And I'm very happy to explain to my patient, don't worry, it's good. So I think we cannot tell more than what it is. We just I try to observe a maximum of patients, and I try to see, okay, I've seen 2 or 3 things, I'm going to share that with my colleagues. But I don't try to explain or go back to the biology, and I think it's a cognitive bias to try to find cause. I don't do anymore.
So maybe the real value of this data is to advise our patients, this thing that you think is bad is good, and this is good for your long term. Let me ask you this, though. You'd presented some prior data about correlation between range of motion at 3 to 6 months and then range of motion later on down the road. So you mentioned early on that you have data at not just 6 months, but also 1 year, 2 year, 5 year, 10 year. What do you think this portends for the long term? So the patient has a little more stiffness early on. Does that persist? Does that improve?
At 2 years, everybody's happy.
You know,
It's just a matter of time.
Got it.
Phillippe, Peter and I were talking a little bit earlier about sort of the American physical therapists who tell our patients if they're a little bit stiff at 6 weeks or 3 months that they're at risk of developing a frozen shoulder, and it's often a very long conversation to say you're okay and this is maybe a good thing. What is your, do you have the same experience?
No, that's exactly what you said previously. I think that perhaps if we could make this mistake. We could say, okay, we've shown that if you recover too quickly, your rate of healing is lower, so we are going to immobilize you during 6 weeks.
Yeah.
But perhaps we will have a lot of frozen shoulder.
Maybe.
That's possible.
Yeah.
That's possible. And I think that there is another mistake. What is our goal?
Yeah.
To have a healed tendon or a happy patient?
Very true, and I think a lot of rotator cuff outcomes, right? Or you have to be very careful about what you're looking at, healing or
Because if you look at
outcomes.
your patient,
Yeah.
even if you have a return, they're happy,
Yeah.
very happy. So I think that now what I do, but it's absolutely not scientific. If it's a young patient, I really want, my goal is really the healing of the tendon. So you'll probably be a bit slower because this is my goal. If it's a 70 years old patient, my goal is more pain and function. I'm less concerned about the healing. So that's why probably I keep the same protocol because I don't want to have a frozen shoulder at 70 or 75 years old.
Mm-hmm.
It's a disaster in their life.
Yeah.
And because they want to play golf, they don't have so many years. so I try to adapt myself, to adapt to each patient.
But you keep the same protocol, but just little things you say to the patient, or
Yeah.
how do you do that in a practical sense?
In practical sense, on a 45 years old isolated suprator, I will probably delay the rehabilitation at 3 weeks. But it's totally the opposite of what we thought.
Mm-hmm.
We thought he was young, good tendon,
Yeah.
and we can move forward quicker,
Yeah.
but probably not.
Any other final thoughts?
I just had one last question, which I don't know if I heard the answer to. Did you look at the PROs, the patient-reported outcomes, and correlate to tendon integrity, speed of recovery? Did you see anything useful there, Phillippe? A lot of data suggests that the patient-reported outcomes are pretty much the same. It depends which one you use. If you use constant score and there's strength involved, of course, less strength in the non-healed tendons. But most other patient-reported outcomes are pretty good, whether the tendon's healed or not.
Yes.
Did you notice anything useful in your large group of patients?
No,
that, could
not
help
yet.
us?
Not yet. I definitely believe in prompts.
Mm-hmm.
I think that it's probably subjective, but it's reported by the patient.
Mm-hmm.
So it's perfect because the patient has the right to be subjective. Because
That's why we're doing it.
Yeah.
Right.
That's perfect, in fact,
Right.
because we are probably not more objective with a good score like ASES score or constant score, because when we see the difference between one observer to the other one and everything, so I definitely like the prompts. I think that what I've learned from my studies is the fact that at 2 years it's okay, at 5 years it's okay, at 10 years it's not. Between healed and non-healed tendon.
Mm-hmm.
Very interesting.
Certainly that
observation.
reflects Moosmeyer's data as well.
Yeah.
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 Mm-hmm.
Absolutely.
Well, congratulations to you for this study as well as all the other phenomenal studies you've done on the cuff and others. I mean, it's a it's a real honor to have you on the podcast, and I'm really thankful you were able to come here and talk to us about this study, so thank you.
My pleasure. It's always a pleasure to share with my friend from United States. It's a big shoulder. It's an amazing family, and we get along very well, in fact, and I'm very happy about that. Thank you so much for the invitation.
Oh, thank you.
Thank you for being here. Thank you. Yeah.
So I'm here with Dr. Eric Ketty and Joseph Ionati of the Cleveland Clinic, and they're here to talk to us about their study, Tendon Retraction After Rotator Cuff Repair and its relationship with postoperative repair integrity. Cleveland Clinic team, welcome to the podcast.
Well, thanks for the invitation.
Yeah, thank you for having us.
And joining us as co-host to discuss the study is, it's Anak Wenzi, might I pronounce it correctly?
That's correct.
Of Duke. Okay, welcome to the podcast.
Thank you. Thanks for having me.
All right, so I know your team has been working on this for a long time. So tell us what led you to study this and what you found.
Well, I'll tell you, the origin of the original study and the concept was related to some of the animal rotator cuff surgery that we did. And in the sheep model and the dog model, unlike what we think of human models, when the tendon repair fails, it fills in with tissue. In fact, it almost always does, because in an immediate weight-bearing animal after cuff repair, it'd be hard to believe that those cuff repairs stay intact. And it was always my assumption, and this dates back now 15, 20 years ago, that that would never happen in the human being, because in the animal, it's extra-articular, the cuff, much like the MCL, and in the human, it's intra-articular, in the sense that you got synovial fluid, and said, well, if the cuff fails, there's always going to be a defect. And, Kathy and I, Kathy Derwin, said, well, how do we know that? How could we measure that? Is there, circumstances in which the tendon repair fails, but it fails in such a way that you get intervening tissue, which we eventually called failure with continuity. So that was the genesis of the first, experiments that we did, so to speak, more precise measurements of how does the human rotator cuff heal. And we assumed from the very, very beginning it was an on or off switch. It either healed or it didn't heal, and you had a gap. You had a synovial-filled gap. And so that was the genesis of the original work, and then we try to figure out, well, how do you measure that? How do you measure retraction of the tendon? How do you compare retraction to, soft tissue healing? So that was the original work, and as I said, it dates back probably 15, maybe more years ago. So we came up with ideas around saying, well, how do you measure that? Well, you can measure tissue by MRI, but it's hard to measure retraction precisely unless you have some kind of marker. So first we started with metal markers, and then we went to metal beads, and then we went from metal beads to barium impregnated suture that you could put in the tendon. And then if you get a time zero low-dose CT and you do 3D imaging, you can measure the relationship of where you put the markers at time zero to the anchors, which are in the bone and presumably not going to move except rare occasion. And now you can measure over time how those markers move from the anchors and where those markers are in relationship to the location of the tendon, where the tear was. And if you compare on the same day imaging by CT for the markers and MRI, which would give you what the tendon looks like in terms of thickness and integrity, then you can begin to understand the relationship between tendon retraction and what we ended up calling failure with continuity, because we felt that, the ideal circumstance would be the tendon stays where you put it, and you get this normal muscle tendon length back, which was critically important to getting muscle function, because we know the muscle tendon length correlates with the rehabilitation and the strength of the muscle. So we ended up calling what we observed some 10 plus years ago failure, because we didn't think that was the right thing for this tendon to retract, but it was healing, so we called it failure with continuity. But that was the original genesis.
Okay, so you came up with this idea, barium-impregnated sutures, low-dose CT, and then tell us in this study, who did you study, what did you find?
Well, Eric, why don't I let Eric answer that? He's been integrally part of the study design, the execution of the study.
Yeah, so we did an initial pilot study of 13 patients now, maybe 10 years ago, where we looked at this initial concept using these metal beads that Joe talked about and kind of understood the surgical technique better and the challenges with trying to suture in these markers, particularly when they're beads, because it's not easy to do. And that led us to develop better techniques, and in particular this barium-impregnated suture, which you can basically pass through tissue and tie like any other suture. So that led to this much larger prospective study in which we've enrolled 121 patients with the goal to take them out to minimum 2-year follow-up and hopefully even longer, where we perform typical double-row rotator cuff repairs on repairable tears, supraspinatus, potentially into infraspinatus, and at the end of these surgeries add these suture markers right at the just medial to the suture line of your medial anchors and medial sutures, so that we could follow how these sutures move over time. And we've added different levels of markers based on the size of the tear. So a small tear might have 2 suture markers, a larger tear may have 3 or 4 suture markers.
121 patients, this is a big group.
Yeah. Yeah, and, we've been fortunate through the work Joe and Kathy did to get NIH funding for this study, and that allowed us to really do this large-scale prospective study to be able to have this advanced imaging over the course of 2 years and really understand this phenomenon better.
Sorry, just a quick question, because this is really fascinating, because I feel like right now we're getting to a point where we talk about what can heal and what can be repaired. And, you would know from your vast experience, it feels like in the past, the ability to repair the tendon at time 0 is what people considered most significant. Surgeons say, well, I can repair any tear. And now we're getting to a point where we're thinking about, well, what heals? Mm-hmm. So does this study give you guys some sort of insight into how we think about what tendon might heal versus what might not heal?
Well, that we haven't got to the answer yet. Our primary objective in this 121 patient study was to describe the gradations or the variations in healing and understand, is there a correlation between tendon retraction, meaning the tendon pulling away from the bone, and gap formation, meaning what you'd call a Sugaya 4 or 5, where you'd say that's a full thickness tear, much like the tear that I repaired. Maybe smaller in size, maybe larger in size, but it's a gap in the tendon. And one of the first things we studied was what is the difference between a Sugaya 1, 2, and 3, meaning, quote, healed, could be thin tissue but healed, and a Sugaya 4 and 5. And the data clearly shows that the amount of retraction that occurs, first of all retraction kind of ends at 6 months, so whatever you typically have at 6 months. But there's a steady increase in the amount of retraction over that 6-month period of time. But that the tendons that don't heal and have a gap clearly have up to about 2 centimeters on average of retraction, whereas it's about 1 centimeter when they do heal, quote, Sugaya 1, 2, and 3. Now, very interestingly, there's huge variation in the Sugaya 1, 2, and 3, where some of them do retract up to 2 centimeters, but they form this tendon-like tissue, much like in this we saw in all of the sheep and dog studies, where that happens 100% of the time. So in humans, it happens about 80% of the time, and that 20% fail and have a gap. So the question is, well, what difference does it make? Is there a difference in outcome, either short-term or longer-term? And that got us to the issue of saying, well, not necessarily what factors are in that variation in gap formation, but what is the clinical significance? And Eric, again, I think is probably best suited to review that data.
But we haven't gotten that far yet, it sounds like.
Well, we've gotten far enough to know that Sugaya 4 and 5, with the large retraction, clearly is correlated with less shoulder strength by multiple measures of shoulder strength, comparing it to the opposite shoulder, comparing it to strength over time. What we were hoping to find, and we have not yet found, is do the patient-reported outcome scores vary based on either retraction or between Sugaya 1, 2, and 3 versus Sugaya 4 and 5. Now, the continuation of this study is to bring all of those patients back for 5-year follow-up. So the assumption is that the quality of healing, meaning the more retraction you get and the thinner that tissue is in the intervening failure with continuity, has a consequence. We don't know that for sure, but that's our hypothesis. And that poor quality tissue might result in either recurrent tears with longer follow-up or changes in their PROMs at 5 years versus 2 years. So all of those patients are coming back for further study. So we're bringing them back now for CT and MRI.
Yeah, I mean, I think the thing that's very exciting about the study is the fact that we've got this cohort of patients, these Sugaya 1, 2s, and 3s, that's a large group. You know, we've got about a 20% failure rate, meaning Sugaya 4 and 5s, which means we've got this large cohort that have this spectrum of retraction. Like Joe said, they average about 1 centimeter of retraction, but it's a spectrum. So we have this ability to understand how that spectrum impacts outcome in terms of PROMs, strength measures, and we even are looking into the potential of how that impacts joint changes. You know, how does that impact muscle changes over time? How does that impact cartilage and joint changes over time?
What percentage of the patients have negligible retraction? So what percentage have maybe less than 5 millimeters
About
to 0?
20%.
So maybe 20% would be considered
What you would say, that's what I expected. When I operated on this patient, that was my goal, that this tendon is going to stay pretty close to where, you know, I put it. And everybody expects it to pull away a little bit. You know, the sutures crimp and they stretch out a little bit and you get some, you know, viscoelasticity of the repair site. But, you know, you'd say that's probably 2 or 3 millimeters. But, you know, when you start to see a centimeter or more, you start to say that's a different mechanism of healing than I was expecting. And that's the majority. You know, that is the more common mechanism of healing. And the question is does it have a consequence? You know, if you're operating on a 50-year-old patient who's going to live 30 years, you know, what are the consequences not at 2 years, maybe not even at 5 years? But we are bringing them all back at 5 years.
Yeah, I mean, I think the other thing that's interesting about this cohort, these are tears that all of us would say we can repair well. So these are tears, small, medium to large, repairable tears that have the ability to be brought back to the tuberosity, to the lateral tuberosity for a double row repair. So these are not our tears where we think they're going to fail. These are the ones we think have the best chance to heal well, and we see this phenomenon even in these tears that we think we're repairing as good as we can.
You know, the average tear size, again, there was a spectrum from, you know, 1 centimeter to 5 centimeters, but the vast majority were these 2.5 centimeter tears where you'd say this is a chip shot. You know, it's 2 anchors, maybe a tendon to tendon repairs, you know, healthy people. You know, if you look at our demographics, you know, this is the sweetheart spot for where you'd say, you know, any day, every day, all day, I'll be happy to fix this cuff tear.
Do you think like a single row would have had potentially different outcomes, or were there other associations you found related to the results?
I mean that's the challenge. You know, this is 121 patients is large, but you know it's hard to get large enough to be able to answer those questions. So we had to make some decisions up front about, you know, how are we going to standardize this to where some of those things aren't going to impact the healing. So we chose the double row technique as the sort of standard way to look at these patients. But that's a great question, and I think those are kind of future questions as you understand this phenomenon and we understand quality of healing better. You can better answer questions like that. You know, does double row versus single row matter? Do biologic applications matter? How does it affect this concept of quality of tendon healing that we think this failure of continuity better illustrates?
One question I've had for you is about this concept of tension. So there's definitely some literature to suggest that repairs that are performed under higher tension are more likely to have that traditional failure, the Sagaya 4-5. So there's been some move in literature to say we should perform our repairs under less tension. That's certainly the single remedialized repair, that movement. It almost seems as though the body is creating that situation for itself. Is this leading, what do you think is the future there? Are we going to be repairing the tears under less tension to create this? Or is it the opposite? Should we be over-tensioning them, anticipating that they'll be stretching out?
I don't know that I know the answer to that question. I can tell you that in this cohort, these were not difficult repairs. I mean, these were not a struggle to say, I can get a double row repair. A lot of these were, double row equivalent, suture bridge technique. So I typically did the traditional double row, but a fair number of suture bridges. So again, these are the kind of cases where you say, boy, if this doesn't heal, I don't know what is not going to heal. The other thing to keep in mind for this study, I mean, this was a huge team of people. I mean, Kathy Derwin was the captain of the ship for this, but there were 6 surgeons that were rigorously trained. Every surgery was supervised by a study personnel. Every note was taken by somebody in the OR. Every case was videoed. Every case had, documented photographs taken. Every patient had MRs and CTs done with a study person in the imaging room to make sure the arm was positioned correctly. Every patient had strength measurements done by 1 or 2 people that were trained. It was a very rigorous study, and it cost the taxpayer a fair amount of money. I mean, this was a $2.5 million, $3 million study to get this done, which, is important in the sense of saying, this type of research where you're doing something prospectively with a very clear question and a very rigorous methodology costs real money. I mean, it can't be done sort of on, nickels and dimes, because you need the level of personnel. It's probably 12 to 15 people involved in this study over a 5-year period of time, actually 6-year period of time.
Well, it sounds like a huge effort, and huge congratulations to you guys for getting it done. I mean, I think it's an enormous contribution to understanding of how cuff healing works. It's really groundbreaking work, and I think it's going to have ripple effects for a long time. And
I hope so.
Our future understanding for how we should be altering our indications and likely surgical technique. Anything else you'd like to share with us?
Yeah, I think if you say what was the motivation to do this study, we thought that if we had a better quantitative measure of healing, that we would have a better tool to measure the value of scaffolds and biologics and other things. Because if you measure healing that by a dichotomous variable, either a hole in the cuff or not a hole in the cuff, it's sometimes hard to pick up subtle differences that are clinically relevant for any biologic or graft. So the original thought was that if we really understood cuff healing in a quantitative way, that we would have a better tool to study some of the biologics in a more randomized clinical trial.
It's so humbling to hear you say that I've done these 20 years of research to develop a tool so that I could begin on the research.
Yes.
Yeah.
Well, and that's
It's
the hard
amazing.
part in terms of convincing NIH to invest the money.
Right.
I mean, that is, if you look at how much money by NIH is given for musculoskeletal research in general, it's low. And if you say, well, how much money do they give for clinically relevant human-based research, it's even less than that. So it's an uphill battle.
Yeah, and I mean, to add to that, as we've talked about, you have these things that we think are meaningful with regards to healing, but may not truly manifest themselves until 5 years, 10 years down the line, and could be true disease-modifying effects, but to do that long-term is challenging because of the issues Joe brings up with funding and being able to have a team together for that long to support that long-term follow-up.
We're hopeful that we find a difference at 5 years with patient-reported outcomes, particularly in this Sugaya 1, 2, and 3 group, that getting tendons not to pull away from the bone is meaningful. because that would open up the whole arena to say, how do we get tendons to heal better and faster, which opens up the arena for justifiable studies for the biologics.
Well, we'll look forward to what the future will hold for this research, and wanted to thank you for coming on and sharing it with us. It's been great to have you on. I appreciate your guys' time. That's about all the time we have for this podcast. Thank you much to our guests. For all of our Shoulder and Elbow listeners out there, don't forget to subscribe, and we will see you next time.